Uh, Thank you, Professor Alan, for seeing the value of this presentation to this meeting. And I ask everybody to have a little bit of patience for my probably boring presentation. So this is about screening of cryptococcal infection in HIV-infected patients visiting two hospital HIV clinics in Addis Ababa, Ethiopia. My home base is Addis Ababa University, School of Medicine. And these are the contributors which I really acknowledge. Three groups from three different institutes in Addis and one group from Emory University, and the study was sponsored by Emory Global Health Institute. The background for the study was that cryptococcal infection is caused by, as you know, an encapsulated yeast called Cryptococcus neoformans, and the portal of entry for the infection is the lungs, with or without pneumonia. And HIV infection and other conditions which might suppress cell-mediated immunity are risk factors for development of disseminated cryptococcal infection involving particularly the CNS. And according to previous estimate in 2008, there were about 1 million cases of diagnosed cryptococcal meningitis in the world, 3/4 of those being in the sub-Saharan Africa, with attending 500,000 deaths because of cryptococcal meningitis, which mounts up to 70% case fatality rate for the cryptococcal meningitis. The strategy of screening for cryptococcal infection in blood of asymptomatic HIV patients with CD4 count less than 200 can be a very good strategy to reduce morbidity and mortality of patients from cryptococcal meningitis. There were a handful of studies in the world, particularly in the developing areas like in Cambodia. There was one study showing very high rate of cryptococcal antigenemia, about 18%, but half of the study population were severely immunocompromised patients, which are inpatients. In Thailand, it was 9.2%, and in sub-Saharan Africa, in the recent times, there was one study in Uganda which shows about 6% of positivity from asymptomatic patients with CD4 of less than 100. In South Africa, it was 7% in patients with CD4 count less than 200. So the objectives of our study was to determine prevalence of asymptomatic cryptococcal infection and its predictive factors in HIV-infected patients visiting two academic hospitals in Addis Ababa. And the subjects were mentioned. The study design was a cross-sectional screening study, which was conducted in about a month and a half time between May 9 and June 25, 2011. By the way, this study is not published. And the study variables were the dependent variable was cryptococcal antigenemia with antigen titers of positive results, and independent variables were CD4 count, socio-demographic variables, other opportunistic infections, and patients on antiretroviral therapy status. The data collection was conducted by a structured questionnaire about demographics, height and weight, HIV history, cryptococcal disease history, and patients' comorbidities and current symptoms of comorbidities. The laboratory testing was carried out by a cryptococcal antigen latex agglutination test, Meridian, and it was performed according to the insert of the manufacturer. And during the laboratory testing, equal volume of serum and phonase solutions were mixed to minimize false positivity, particularly because of rheumatoid factor and other interferences. The inclusion criteria were age more than or equal to 18 years old, confirmed HIV infection, and CD4 count less than 200. And the exclusion criteria was patients who are previously treated for cryptococcal infections in the last 3 months and who are taking systemic antifungal agents at the time of visit, because cryptococcus is a pretty sensitive fungus for a lot of systemic antifungal agents. The data analysis was pretty usual. Raw data was entered in EPINFO. Epidata and statistical analysis was performed using Stata. Descriptive data analysis was utilized to determine prevalence, and multivariate logistic regression was done to assess relationship between risk factors and positive cryptococcal antigen tests. So these are the results. Until now, a total of 256 patients were screened for cryptococcal antigenemia. Of these, 55% were female, and the rest males, which is pretty representative of our HIV population. In the heterosexual transmission groups, our population contains about 60% females, and those people, the median age in the tested group was about 35 years. Of these patients, about 10%, which are 26 patients, were positive. And the range of the titer for serum cryptococcal antigen was 128 to 128. This is a table showing a relationship of dichotomous variables with cryptococcal antigen positivity. So there were 4 variables which were found to be associated with cryptococcal antigen positivity in a univariate analysis. So this is what surprised us, and it looks like a false association because about 72% of our patient population were taking ART during the test time. It's only 28% of patients who were naive for ART, and it looks like that the patients who are taking ART are overrepresented in our tested population. But even then, there were those patients who are taking ART were 3 times more likely to have antigen positivity, and we intend to look back to our study data to figure out whether this is a marker of just advanced immune suppression or if there is any other form of relationship. CD4, age, and BMI were associated with positivity in a univariate analysis, but only CD4 count and age were found to be independently associated in a multivariate analysis. Among the associated variables, CD4 count less than 100 tends to be strongly associated with positive cryptococcal antigenemia with adjusted odds ratio of 3.7 with p-value less than 0.001. So the conclusion was serum cryptococcal antigenemia was common in asymptomatic patients in our clinics, and we tend to make recommendations that all patients, irrespective of their antiretroviral treatment status, with CD4 count less than 200 should be screened for asymptomatic cryptococcal infection. Thank you for my home base, for the organizers of this conference, and of course for my personal assistants.